for supporting this fantastic initiative. Today's topic is very complementary to all of the talks we have had on various aspects of dementias. We've had dementia diagnostics, we've had a talk on dementia and Parkinsonian syndromes, which I did, and we have had talks on biomarkers, investigations, etc. So it's only natural that this particular area is also covered adequately. The treatment, identification, detection, and treatment of behavioral and psychological symptoms in dementia. Why? Because these symptoms, as you know, in clinical practice, is highly prevalent. It's distressing to the patients and their carers. It increases distress in patients. It worsens their quality of life, and it also worsens the quality of life for the carers. Caregiver burden is a major problem with all of the whole range of behavioral and psychological symptoms we'll be hearing about. It is also expensive in that patients with BPSD end up getting hospitalized, end up getting institutionalized. So there's clear increase in hospitalization and institutionalization attached to some of these symptoms. So without further ado, I'd like to invite our own Dr. Mohandas to cover the detection and also non-pharmacological and pharmacological management of what he has called as neuropsychiatric symptoms of dementias.
Can you see the slides?
Yes. You need to go into the presentation mode.
Yeah, that I will do it. Is it okay?
It looks good.
Okay, can I start it?
Yes.
Yeah. Thank you very much, Chitra. You have covered everything. So I will go a little bit faster. I am putting it as not BPSD, I am putting it as NPSD, neuropsychiatric symptoms of dementia, and instead of BPSD. BPSD, the term has come first in International Journal of Psychogeriatrics, I think, initially. But currently, because of the new classification of DSM-5, neurocognitive disorders, it is worthwhile to put it NPSD. Nobody has used it. They usually say neuropsychiatric symptoms, but I am putting it NPSD instead of BPSD. We have to know the basic background. It is a spectrum of non-cognitive and non-neurological symptoms of dementia, such as agitation, aggression, psychosis, depression, apathy. At least 80, if not more, people with the dementia at some stage experience NPSD. Apathy, can you hear me?
Yes.
Yeah. Apathy, anxiety, depression, agitation, psychosis, that is hallucinations, delusions, sleep disturbance, dysphoria, aberrant motor activity, and disinhibition. These are the components. So we'll see the prevalence, agitation, aggression. It is varied depending upon the stage of dementia. However, the average is put as 40%. It can vary. Apathy is also, it can vary 55 to 90%, depending upon the stage of the dementia, depending on the type of the dementia. Depression, 42%, but it can range from 19 to 78%. Anxiety, 16 to 35%. Psychotic symptoms, delusions, 31%. Hallucinations, 16%. Wandering, very difficult to get the prevalence, but it varies from 17.4 to 63%. But sleep disturbance is also common around 40%. Disinhibited behavior 17%, but some cases of FTD, frontotemporal dementia, it may go up. This is one of the NPI items which was done in 2020, aging and mental health, delusions, hallucination, agitation, depression, anxiety, euphoria, apathy, disinhibition, irritability, aberrant behavior, sleep disturbance, eating changes. Depending upon the stages, it can vary. You can go through the journal Aging and Mental Health. It will be published soon. It is online. So agitation means what? Walking aimlessly, pacing, trailing, restlessness, repetitive action. Aggression can be either physical aggression or verbal aggression or even resistance. Apathy, withdrawn, lack of interest in a motivation. Depression, everybody knows about it. Psychosis also have already told, including misidentification. Disinhibition can be cognitive disinhibition, behavioral disinhibition, and socially and sexually inappropriate behavior. You can classify into three groups. Group 1, most common, most distressing. Psychological is delusions, hallucination, depressed mood, sleeplessness. Behavioral is physical aggression, restlessness. Moderately common or moderately distressing is psychological, and behavioral is again agitation, wandering, screaming. Less common, but you may manage crying, cursing, lack of drive, repetitive questioning, and anxiety. But when we deal with this, you have to see which one is druggable or not. Am I audible?
Yes.
Okay. Drug responsive symptoms are anxiety, agitation, depressed mood, apathy and negativism to some extent, regressive behavior, insomnia, hyperactivism, verbal aggressiveness, delusions, and hallucination. However, drugs may not be effective. Basically, non-pharmacological methods are to be employed for all these symptoms, but especially wandering pacing, interfering behavior, repetitive questioning, mannerism, intrusiveness, polyphagia, and autolesionism. So, depression, anxiety, the contributing factors are depression or anxiety can aggravate. Delirium, you have to rule out metabolic, toxic, or infections. Untreated pain, before you do anything, if you have to look for any painful condition, you treat it. They may not be able to communicate well. Infection, especially urinary tract infection or pneumonia, always rule out. Dehydration, proper hydration is needed. Even constipation, they may be agitated, restless. See whether their bowels are not cooperative. You have to see that. Fatigue, they may not be able to communicate the way they should. Hearing and visual impairment. And other contributing factors are either understimulation or overstimulation. But mainly, when we see in a residential setup or even at home, adjustment issues, difficult relationship with carer, even the family members, if they are not educated well, separation from family or new environment, if they are put in a new place, lack of privacy, lack of space, even the lighting, crowding, perceived feeling of insecurity. But if they are exposed to COVID and quarantine and loneliness, I think they will cope up with those things. We are all, though we are not dependent so far, we are coping with loneliness, coping up. And drugs. So we use least amount of drug if possible in NPST or BPST. It may be secondary to physical problems related to activity intrinsic to the disease as a consequence of depression or delusion, which I've told. Easy to use the mnemonics: pain, physical, pain and infection, activity, getting dressed, new caregiver, intrinsic personality change or delusion. This is called pain. And Dr. Chitramohan has already told the impact: premature institutionalization, financial cost, caregiver burden. The 9 A's, common effects of dementia on the person's functions and behavior. In the literature, you will see 7 A's. I added 2 more. So this is my 9 A's. Anosognosia, amnesia, aphasia, agnosia, apraxia, altered perception, apathy, aggression or agitation, altered sleep. These are the 9 A's. I need not describe that, you know it. But Better to do some checklist when you are having a client. How often during the last week that you have observed wandered aimlessly around the home or from home during the day? It can be accounted by the relative or caregiver. Been uncooperative or resistive to help from others, made physical attacks towards others, hits, bites, scratches, kicks and spits, verbal attacks towards others, shouts, swears and curses, behave in public at home in a way that caused you embarrassment, demanding your time or attention, was awake and up during the night for no apparent reason. Many of the dementia patients will sleep for 2 hours, then they think that the next day has a shade in. So they will ask the relatives or other people, why don't you get up? It is next day morning. So you have to be little bit careful. Had delusion that the spouse was not spouse, home was not home, there were people in home, even passage or presence delusions or stealing something out. Neighbors have taken away some household things. Acted depressed or downhearted, initiated but was engaged in pleasurable activities. Are they motivated? Showed signs of nervousness or anxiety, required prompting to undertake usual activities of daily living, that's bathing and even brushing, had hallucinations, and initiated was interested in conversation with you and other people, characteristic delusion, possible or probable AD, onset of these are the proposed criteria for psychosis. How will you differentiate from late onset schizophrenia from psychosis? You will have characteristic delusion, usually presence delusion, passage delusion, or delusion of infidelity. You will have dementia criteria satisfied. Onset of psychotic symptoms after the onset of dementia symptoms, present at least intermittently for at least 1 month, severe enough to disrupt patient functioning, not better accounted for any other psychotic disorder, medical conditions, or even drug. Does not occur during delirium. Psychosis in AD, 30 to 50%. It varies. It can from 19% to 90% in some cases. Bizarre delusions rare. Misidentification common. Mostly visual hallucination, especially Lewy body and FTD. First-rank symptoms rare. Suicidality rare. Past history rare, unlike usual psychosis. Remission frequent. Need for maintenance care. Antipsychotics, if at all you use, you have to use very low, especially atypical ones. What are the neural correlates? Apathy, high neuronal loss, especially in frontal and subcortical circuit. Psychosis is higher neurofibrillary tangle towns in middle frontal, superior temporal gyrus, inferior parietal areas. Also reduction in prefrontal, left frontotemporal and right parietal signals. Active agitation, aggression, bilateral orbitofrontal and anterior cingulate tangle burden. Even orbitofrontal abnormality is more common in frontotemporal dementia. This is, we are talking about Alzheimer's, basically, tangle burden and frontotemporal hypoperfusion. Depression, hypometabolism in the superior frontal areas of cortex. Later on, you can get classical hypofrontality. Not only there, even anterior cingulate areas and even subdural area. Anxiety, reduced metabolism in parietal cortex. Some people are disinhibited. What is the neuroimaging data? This has come recently in Cortex Journal, not yet published, it is in press. If you see the red signals, this one, red one, that is the structural changes. The blue one is the functional changes. Yellow is the metabolic changes. And violet is the structural and functional. left and right orbitofrontal cortex, these are the structural changes. Right inferior and middle frontal cortex, right inferior, middle and superior gyri, temporal pollen subgenual cingulate. Functionally, different functional activity, right angular cortex and prefrontal cortex, I am not going to details. Metabolic differences in the posterior orbitofrontal cortex, medial frontal cortex, limbic structures including hippocampus, amygdala, caudate nucleus, nucleus accumbens, and insula especially anterior insula. Now you can get overlapping regions, both metabolic and functional ones, in both structural and functional studies in right lateral prefrontal cortex and left inferior frontopolar regions. How will you assess it? Always you have to assess. We have got many scales. Some of the scales I will just mention. We had a discussion on scales on cognitive scales by Madhuranath. Some of them he has talked about it. So I will not touch upon it. We have AD, 26 items rated on 0 to 3 point scale covering behavioral symptom. Takes 20 minutes. It is a 75-point scale. NPI, neuropsychiatric inventory, 12 items covering behavioral symptoms based on severity, scores 1 to 3, and frequency 1 to 4, takes around half an hour. It is a 144-point scale. Behavior rating scale for dementia of the consortium to establish a registry of Alzheimer's disease. It is called SARAD BRST, 46 items on 0 to 5-point scale, covering behavioral symptoms. 40 minutes it will take, 148-point scale. Who will assess all these things? Either a trained worker or even nurses can do it, but if it's a trained clinician, it will be better. Cohen-Mansfield agitation inventory, you had a question. 29 items on a 7-point scale covering aggression, agitation, 15 minutes, 203-point scale. Cornell scales for depression, dementia, CSDD, 19 items, 0-2-point scale covering depressive symptom, and dementia behavior disturbance scales, 28 time scales. Because of the time constraint, and I am not talking about scales, I am not giving you all the details of the scales, which I do have it, but I cannot share it now. Cohen-Mansfield agitation inventory, which we had asked questions, 29 items, which are they? Physical aggressive, hitting, kicking, grabbing onto people, pushing, throwing, biting, scratching, spitting, hurting self-others, tearing things or destroying property, making physical, sexual advances. Non-aggressive one, pace, aimless wandering, inappropriate dress or disrobing, trying to get into a different place, intentional falling, and inappropriate handling, hiding things, hoarding things, performing repetitive mannerism, general restlessness. All these things you can get in various stages. You can have verbal aggressive, screaming, making verbal and sexual advances, cursing or verbal aggression, verbal non-aggressive, repetitive sentences or question, strange noises, weird laughter or crying, complaining, negativism and non-cooperativeness, constant unwarranted request for attention for help. This is the 29 item Cohen-Mansfield agitation, very easy to use. Middleham frontalis corporal MFS, 10 items including disinhibition, impaired emotional control or cognitive inhibition scores scales I am not covering. Frontal behavior inventory, designed for frontotemporal dementia patients to catch both behavior and personal changes, include 24 items. 12 items represent positive symptoms involving diminished inhibition, such as perseveration, excessive jocularity, poor judgment, inappropriate. Many people use DAPHNE scale consisting of 10 items spread across 6 domains: diminution, apathy, perseveration, hyperorality, and personal neglect. And DAPHNE scale consisting of 10 items spread across 6 domains: diminution, apathy, perseveration, hyperorality, and personal neglect and loss of empathy. Within disinhibition, if you want to focus on disinhibition, there are 4 items, each score. And Chitramohan will be knowing the Cambridge Behavior Inventory, 18 items questionnaire, memory, orientation, attention, everyday skills, self-care, etc. But 13 subsections are scored on a 4-point scale. It can be easy to differentiate Alzheimer's disease from frontotemporal dementias. There's a shorter version of 45 items. This is the DAPHNE scale. I don't know whether it is very clear. This has come in Dementia Geriatric Cognitive Disorder Extra Journal. The disinhibition is basically loss of social convenience, inappropriate joviality, unstrained spending habits, sexual disinhibition, and apathy, loss of initiative, loss of empathy, and perseveration. I will not go into details. Hyperorality, neglect, everything is covered in DAPHNE scale. You can go through this journal and see whether you can download. Very difficult to get it downloaded. Barratt impulsiveness scale. If you want to measure impulsivity, it includes 30 items that are scored to yield 6 first-order factors: attention, motor, self-control, cognitive complexity, perseverance, and cognitive instability and impulsiveness. And second-order factors, non-planning, impulsiveness. Now we will come to the management. This is the crux. Always you have to adopt a DICE model. What is DICE? Describe the type of behavior. Explain, are we going to target this type of behavior? Investigate, always investigate why this is so, especially why this person is behaving like this. Is it because of the constipation, urine infection, or some other factors, physical causes? Understand the behavior using P.I.E.C.E.S, pieces. Create a plan, educate, offer solution, make referrals. That is a team workup and follow-up. What is risks? Roaming, wandering, getting lost. Roaming, wandering, getting lost. Is it the target behavior? Or is it imminent physical harm? Fire, falls, or frailty? Or is it, are we dealing with the delirium? So take it out, deal with that. Suicidal ideation, kinship or relationship, even the caregivers, self-neglect, safe driving, substance abuse. You have to assess that. That's the risk. What is P.I.E.C.E.S? Physical, intellectual, emotional capabilities, environment, including lighting, temperature, colors, noise, social and cultural factors, and possible triggers and causes identified. So P.I.E.C.E.S means physical, intellectual, emotional capabilities, environment, and socio-cultural factors. That is the P.I.E.C.E.S. So non-pharmacological approach, modify environment if possible. Optimize stimulation. No overstimulation, no understimulation, including lighting, the facilities. Use consistent routines. Maintain a routine. Don't shift every day. You have to have a uniform pattern. And if needed, you can adapt. Assess, adapt to aggravating factors. You have to know the behavior management principles. You have to educate, if possible, to the patient, certain aspects, or even caregiver or the family members. Support of patients and caregivers. Physical environment, the keys are stress-free, safe, friendly, comfortable, constant. 1 minute. 1 minute. Hello. ഞാനൊരു മീറ്റിങ്ങിലാടാ. എന്താ 10 minute. Sorry, I had an international call. So the environment has to be stress-free, safe, friendly, comfortable, constant, familiar, lighted, very important, obstacle-free. So you have to design an environment. The guiding principle of care is that caregiver must modify the environment or their own behavior because the client is not capable of modifying his or her own response unless the situation changes. So you are the master, you have to do it. Address any underlying or comorbid condition, maintain environmental stability and calmness, prevent major injuries, wait, maintain verbal and non-verbal interaction, promote independence, mediate family stress and even caregiver burden, preserve patient dignity, intervene for safety as indicated, and if there's an issue, direct other types of way. Remain calm, do not overreact or confront. Even if they do it, you keep it cool and divert it. Evaluate event-specific factors and intervene appropriately. Try to understand what is being communicated. Attempt to satisfy request if feasible. Divert attention to diffuse behavior. Involve staff members who might have positive rapport with the patient. You may have to change the staff or even caretaker. Be aware of the racial or gender bias, very important, that may be associated. Provide calm environment and decrease stimulation. Be familiar with and watch for the early signs of agitation and intervene to prevent catastrophic reactions. Involve families in care planning. In Kerala and mainly in India, mainly family members are involved, especially female members, for understanding the patient's preferences. Involve interdisciplinary team for long-term management. Always discuss, consult, take the input. Sensory, what are the non-pharmacological approach? Sensory stimulation. What are they? Acupressure. What type of acupressure or acupuncture you can do it? I will not discuss. I am a trained acupuncturist. Aromatherapy. I will not discuss. You can read. Massage. Not the sexual massage. Touch therapy. Light therapy. Garden activities. Music and dance therapy. Especially music and dance therapy. Even environmental enrichment can be neuroplastic and multisensory stimulation. I don't have much idea about it. Chitra Mohan might be able to tell me about it. Cognitive and emotional oriented approaches, cognitive stimulation, we are going to hear tomorrow, Chitra. Yeah. Reminiscence therapy. You always talk about the past, which are very important in their life. Some, maybe even the smell, even some animals, even the flowers or environment, or even close friends. You can try to bring him back to that place and make him happy. Validation therapy, simulated presence therapy. This we can enact and do it. You can make things done. Even the room, you have to make the clock in a peculiar way, not the numbers, but specifically the arms of the clock has to be put in that such a way, colored. You can tell even in the environment, even at home, Bathroom can be, the doors can be in a special color. Kitchen can be, the door can be in a special color. So you can say this color, this is kitchen. This color, this is what you call toilet. Behavior management techniques, multi-component intervention, other therapies, education of patients, caregivers, exercise if possible, animal-assisted therapy involving real or robotic animals. What about the evidence base, especially on non-pharmacological interventions in apathy? This question was asked. Music therapy, multi-sensory stimulation, cognitive stimulation, PET therapy, there was robust evidence. But reminiscence therapy, therapeutic conversation, muscle relaxation, art therapy, etc., need validation further. This you can read from a 2020 article which has come in World Views and Evidence-Based Nursing, still in press, but you can try to see. What is the effect of music therapy? Patients with dementia, a systematic survey. This is also, you can read in Geriatrics Journal 2020. I don't know, it is published now. 82 studies, 43 interventional clinical trials, and 39 systematic reviews or meta-analysis. Significant improvements in verbal fluency occurred after music therapy, with significant reduction in anxiety, depression, apathy. No significant improvement in cognition or daily function, and quality of life and agitation, ambiguous results. PARO robotic PET therapy, especially fashionable in Japan and some of the European places. It is an interactive robot developed by a leading Japanese company, and PARO is the 8th generation design, 5 kinds of sensors. The robot has got tactile, light, audition, temperature, and posture sensors, and can recognize light and dark. He feels being stroked and beaten by tactile sensor. And this can recognize direction of voice and words, such as name, greetings, praise with its audio sensor. It has been found to reduce patient stress and caregivers, stimulate interaction between patients and caregivers, improve relaxation. Intervention with a robotic PET 3 times weekly per 20 minutes was found to reduce need for pain medication and psychoactive medication. This has come in Journal of Alzheimer's disease. Pharmacological agents, no FDA-approved medication for behavior and disturbance in dementia. Evidence to support atypical antipsychotics modest and associated with harms, including increased mortality. Pharmacological measures should be considered first line for 3 specific scenarios: severe major depression with or without suicidal ideation, psychosis causing harm or potential for harm, aggression with risk to self or others. This recent article by Gerlach, 2020. So you have to have a specific indication. It has to be severe symptom and necessity for immediate intervention. And you have to first try non-pharmacological techniques. If there are no alternative approaches, you can try. Drugs may be withdrawn after 3 months if this behavior doesn't improve. So 3 T's in pharmacological management: target, specific target symptom; titration, starting dose low; titrate upwards to effective dose, time is limited, even 1 to 3 months. Target symptom: hallucination, hostility, aggressiveness, sleep disturbance, atypical antipsychotics; depression and OCD, SSRIs, anxiety, agitation, sleep disturbances. Avoid benzodiazepine if needed, PRN medication. Recurrent, best is trazolone type of things. Recurrent agitation, sleep disturbance, disruptive behavior, rarely anticonvulsant carbamazepine. So, cognitive impairments, best is cholinergic inhibitors or even NMDA antagonists. And if there is psychosis which are not being controlled, by non-pharmacological symptom, or if there's a specific indication, severe depression, severe aggression with harm to patient or client or even others, then sometimes even apathy and emotional withdrawal. So this you know it, this journal you have to read, CNS Drugs 2020, Management of Dementia-related Psychosis. It is this is a beautiful article which has come very recently. Pharmacological activities, receptor-based, including the newer one, cannabinoid, and targeting 5-HT6 receptors. So you know about atypical antipsychotics, antidepressants, and anticonvulsant, carbamazepine, evidence is very poor, and anti-dementia drug, you know it. Donepezil, you can try, you know the dosing. Risperidone, very low dosage. Olanzapine, very low dose. Quetiapine, gradually increase. Aripiprazole if needed, but evidence is very, very selected studies. Anticonvulsant, oxcarbazepine, some people have tried, but questionable. Pregabalin, questionable. Prazosin, now it is under trial, and experimental drugs, including cannabidiol. Antidepressants, antipsychotic, anticonvulsant, cholinesterase inhibitors. Meta-analysis indicates only 2 medications had significant higher response. That is dextromethorphan, quinidine, and also risperidone. This has come in British Journal of Clinical Psychopharmacology, 2018. No individual SSRI was found to have significantly greater effect than placebo. Carbamazepine had inferior acceptability when compared to the donepezil or haloperidol. Very rarely people use it. Second meta-analysis, aripiprazole, quetiapine, risperidone were associated with improved symptom. Some people say, but associated with risperidone increased risk of cerebrovascular accident. Available data indicate antipsychotics should be reserved for treating BPSD or NTSD that are severe or refractory to non-pharmacological management strategies. Systematic reviews, 12 meta-analysis and 10 studies evaluated atypical antipsychotics and 2 studies typical antipsychotics. Modest efficacy, but risk of death is 1.36 risk of death. It is more. Use of antipsychotics, risk of death 1.6 to 1.7 times in elderly people. So, psychosis, agitation, depression, they will respond to drugs, but be careful. APA practice guidelines says when no clinically significant response is observed in an adequate dose of an antipsychotic for the treatment of psychosis or agitation of 4-week trial, 1 month, medication should be tapered or withdrawn. 4 months, this is a beautiful article, less is more. 4-month multicenter article, it is coming in American Journal of Geriatric Psychiatry, it is in the press. If you do it, a medication review with good mentoring, you can reduce the prescription of psychotropic drugs in nursing home patients without a deterioration of BPSD, and yet independence of ADL improved. It's a beautiful article. This is a CITAD, which was in 2014, that Porstenson suggested some it may be improved. Some patients had improvement in behavioral and psychological symptoms. This is the last part of the presentation. Sequential drug treatment algorithm. This has come in Journal of Psychopharmacology 2008. Efficacy, time to onset, tolerability, ease of use, and efficacy other than the behavior symptom. So this is the green is there, yellow is there, red is there. Step 1 is risperidone, then quetiapine, then aripiprazole, same, carbamazepine, citalopram, gabapentin, and prazosin. If you see, efficacy is green, risperidone, time to onset is good, then quetiapine and aripiprazole may be tried. Quetiapine has got other efficacy also. Carbamazepine, not much. Other efficacy, yes. Citalopram, other efficacy, severe depression. Gabapentin, other efficacy means sleep. Prazosin, still experimental. Green indicates the drug was given the highest rating, risperidone. And yellow, intermediate aripiprazole. And red, other drugs. But other indication like depression or things, citalopram. So this is the main pathway: risperidone, aripiprazole, quetiapine, carbamazepine, citalopram, gabapentin, prazosin, combination or ECT. PRN medication, even for sleep, trazodone or lorazepam, only PRN. And cholinesterase inhibitors or memantine has to be continued. New drugs in pipeline: pimavanserin, siloinositol, Mibapator, I cannot spell it rightly. Lumateperone, they tried it, but not that effective. That trial was withdrawn, but lumateperone is still a good drug. It will come for schizophrenia with a depression, cognitive symptom. I will not discuss much on lumateperone. It's a alpha 2C adenoceptor antagonist is being tried, and metabotropic glutamatergic 2 receptor agonist is tried, dextromethorphan, quinidine, brexpiprazole, prazosin, cannabinoids, even mirtazapine is still being tried. We'll come to the tail piece. People might ask, how will I treat hypersexuality? There are no specific indication. Discontinuation, no specific medication. Discontinuation medication that could potentially worsen disinhibition, such as benzodiazepine or dopamine agonist. Case reports are there, especially for SSRIs, anti-androgen, estrogen, antipsychotics, acetylcholinesterase inhibitors, increasing the dosage, some of the anticonvulsants, alone or combination, only case reports. ECT can be given in some people, maybe safe option to reduce symptoms of agitation, aggression. Patient with dementia whose behavior are refractory to medication management. What about brain stimulation? RTMS rather than direct cortical stimulation was capable of persistently improving BPSD at an early stage after treatment. More trials are warranted. 2020, I think it is published now. I think I have to say thanks a lot. I have taken enough time. Questions, Chitra, back to you.
Thank you. Thank you for that wonderful overview of what you call as NPSD, and you covered quite a lot and very comprehensive. I think, Chintan, just to add a few things, you have quite rightly pointed out in the main pathway for treatment of anger agitation syndromes in particular, I wanted to highlight to the audience, there's no place for valproate. Valproate in particular can worsen cognitive decline. And there are new studies to show that valproate can actually induce brain changes. So you will not rush to make a diagnosis of dementia in somebody who has taken more than, on average, 2 grams of valproate for epilepsy, or as an anti-bipolar medication. You'll have to give time before you will rush to a diagnosis of dementia in such a patients. We've seen cases of reversibility in the cognitive dysfunction with people with valproate in doses that are high. There's also no place in the main pathway for trazodone. This was Terry et al. Study in 2000 that did not meet the primary endpoint in terms of its impact on NPI or CGI-C. Out of the antipsychotics, as Professor Mohandas showed, in terms of the traffic light situation, risperidone has the best data in terms of efficacy in low doses. One has to be careful. And prescribing risperidone ad infinitum without a review is a clinically negligent practice, as Professor Mohandas highlighted. It's short-term treatment, and drug withdrawal must be attempted. And there are studies such as DART-AD and others that have clearly shown people can come off antipsychotic medications. Quetiapine in particular, as you saw, is a weak drug in anti-aggression syndromes. As Professor Mohandas highlighted, it has other efficacies, but it is second line, if not third line. And in the KT-AD study, extension of KT-AD study by the Californian Professor Schneider, risperidone and olanzapine did better than low-dose quetiapine. That's an important finding in the KT-AD study, the famous KT study extension. And amongst the citalopram evidence Professor Mohandas showed, post-Einstein studies and Schneider's subsequent studies in 2016, 2 years later, citalopram is efficacious in moderate to severe agitations, mainly in outpatients. And those are the characteristics of those patients who did well on citalopram. And also, insufficient improvement in any of these symptoms after you have tried medications is a predictor. If you don't get any improvement in 2 weeks, that's a predictor of poor response in time to come. But there is a subgroup of patients I've seen after extensive clinical practice, anybody with more severe symptoms at baseline, that is NPI more than 14, are more likely to need long-term treatment with antipsychotic medications with high relapse rates. The final point I want to make, clinical point for all of you, is that those who are on non-steroidal anti-inflammatory medications, they have a higher risk for cardiovascular mortality or cerebrovascular problems with antipsychotic medications. And equally, my colleague Howard studies from published in British Journal of Psychiatry in 2016-17, Professor Howard from Institute of Psychiatry showed those patients with dementia and depression and even delusional symptoms, that is said to be protective against the increased mortality. On that note, let's open the floor for discussion, unless Dr. Matthew Abraham has joined us.
Sir, I think, yeah, Dr. Matthew will take some time.
Okay,
Dr.
no
Indu,
problem.
There's a question. Yeah, we can start with the question.
Start with the questions, yeah.
Yeah. Dr. Indu, you can ask your question.
Sir, thank you for that excellent presentation. My question is regarding from the Lewy body disease, which would be the first antipsychotic of choice, and what side effects should we watch out for when we start antipsychotics?
And I think we have discussed earlier, Indu. I think you didn't attend or you now attended. Lewy body dementia people are very, very hypersensitive to antipsychotics. If at all you want to use it, you have start it very low dosage. Low dosage means low dose of risperidone. Even some people try even clozapine lowest dosage, ON 6.25. But the problem with that is severe hypotension. We have to postal hypotension very common. So you have to be very, very careful in Lewy body. So you cannot selectively say this drug is better than others. Any antipsychotics will do, but if at all you use it, please try atypical antipsychotic, considering hypersensitivity and hypotension. Quetiapine is going to produce severe hypotension. Risperidone can produce hypotension. Clozapine can produce, but only lower dosage may not produce. But be careful when you use it. I think I have answered you.
Just to, if I may, Chintan, add to that.
Please, please.
Professor Mohandas did highlight to you in the tail piece a drug called pimavanserin. Pimavanserin is already licensed in the US for
but
Parkinson's disease.
It has not come.
Sure, eventually it will come for Parkinson's disease psychosis. It is a pure 5-HT2A2C inverse agonist, right? So it has no D2 action. So it's pretty good for people with Parkinson's disease because it will not worsen their motor symptoms because it's a 5-HT2A2C antagonist. The aripiprazole studies are mainly negative studies. Even though it's a partial agonist, it still has antagonism at D2 receptor. So it can technically worsen but it is better than risperidone or a stronger D2 blocker like amisulpride. But certainly, Professor Mohandas is right, quetiapine. I think Dr. Madhusudan, I saw the name, I don't know, it's the same Madhusudan. He was talking about mainly clozapine in the last discussion. And also, like Professor Mohandas said, quetiapine has placebo-level EPS across the dose range. But the problem with quetiapine, as Professor Mohandas said, I want to highlight again, it's important. Postural hypertension is a major problem with quetiapine. Sedation, postural hypotension, and anticholinergic side effects. It may be helpful with Parkinsonian symptoms, but it worsens your cognitions. That's the problem with quetiapine.
In Indu, 2 drugs which are being tried now, anyway, I have discussed on Parkinson's disease psychosis earlier. Pimavanserin and brexpiprazole, people are trying, but we do not have the data clear. Mohan is correct.
Chintan.
Yeah, Dr. P.I.E.C.E.S. Mr.
Okay, that's okay. First, unmute and ask your question.
Oh, unmute. Oh, of course. How do I do that?
Yeah, you're unmuted.
Yeah, okay. Can I talk? Can you hear me?
We can hear you.
Yeah, we can.
Yeah. Regarding sexual disinhibition, patient with dementia, I'm an experienced non-medical prescriber. I've used it with a lot of success from families when I use paroxetine. Based on the fact that when paroxetine first came about a few years ago, a younger adult who'd been prescribed paroxetine for depression had refused taking them because of the side effect of it's abates their sexual appetite. So that's the reason they didn't want to take it. So we've used it in dementia, people who present with sexual disinhibition, with great success, I must say. What do you think about that?
Yeah, all SSRIs can reduce. But paroxetine, because of that effect. But mind you, paroxetine has got anticholinergic effect also. If you know very well, in a dementia patient using paroxetine, in a theoretical model, we cannot accept. Number 2, paroxetine and fluoxetine has got maximum drug-drug interactions. So the sexual disinhibition might have been because of the serotonergic action. Okay, that would have been okay. That is possible. Yeah, but that citalopram can be effective. But paroxetine, it has got also anticholinergic effect.
Yeah.
Paroxetine has got P452D6 interaction. Be careful. Okay. If the patient has not tolerated, wonderful. Okay.
Yeah. But I always tell patients, the relatives, the reason I'm prescribing it because of the reported side effect in the adult, and they understand that. They say they're happy to give it a go.
Okay.
Thank you.
Dr. Suresh Kota, sir.
Good evening.
Yes, good evening.
It was an excellent lecture by both of you, sir. I have only one question regarding the role of ECT in behavioral disturbance, especially in dementia. Already existing memory disturbances and cognitive dysfunctions, won't they worsen, sir?
The answer is very simple. If it is a desperate remedy, if the other outlets are all blocked, you may still try only to control the severe aggression and agitation or psychosis. And as you pretty well know, dementia, ECT can produce memory dysfunction, but it is reversible. Basically, if you know, is ECT will produce a memory dysfunction or will it is a procognitive? I can argue that it is procognitive also, depending upon the mouse, if I were sprouting, etc. But here, you are giving only when other avenues are completely lost, only you are giving for a symptomatic management. Within 2-3 weeks, nothing will happen. The dementia, everything will be okay. Okay, that will be there.
Sir, have you given personally your experience?
I have given in Parkinson's with behavior problems, I have given ECT. But when we give in these people ECT, Parkinson's disease, I don't usually use the anesthesia in the same dosage, only half of it. and we have to be a little bit careful. Succinylcholine also half of it. Okay.
Thank you, sir.
Chintran, if I may add to it, Dr. Suresh, I have never ever in my 30 years practice ever seen ECT being given for control of purely behavioral and psychological symptoms. As Professor Mohandas has highlighted, it's a last resort treatment, and I have never had to resort to ECT ever in my clinical practice. Let us ask Dr. Manoj Rajagopal from UK. Have you ever seen ECT being used for control of behavioral and psychological symptoms?
No, you're right. We haven't been using, and say in UK it is not licensed. So you're absolutely right, Dr. Chitramohan and Dr. Mohandas. We don't say that. I've been told that there is a new European study which has just started, and I think Dr. Mohandas did mention that where they are trying ECTs, but still it's not in practice. We don't use it anywhere in UK. Thank you.
There are reports, if you remember well, almost 15 years back, there were reviews on ECT for movement disorders. Okay?
Yeah.
And when a person is not taking medicine, if it is intractable, we can give ECT for even controlling movement disorders. I have tried. Okay?
Yeah.
Personally, I've tried.
Yeah.
Not in dementia, Parkinson.
Sure. What will be interesting though, Mohandas, is what you said. RTMS, TCDS.
Yes.
They are non-invasive kind of treatments, and you did cover all that earlier anyways.
Yeah, I have covered just because I was talking about only time was limited.
Sure.
RTMS is still being tried.
Yeah.
The problem with RTMS is, will you focus right-sided or left-sided? That is a big problem.
Yeah.
And depending upon the measures, it's supposed to be better than transcortical direct stimulation. Some articles are there, but evidence is still, we have to wait,
Sure.
So that's why I didn't. ECT also, there are papers. That's why I just mentioned one.
Yeah.
Okay.
Sure. Chintran, next one.
Yeah, next is from Dr. Nimita. Nimita, if you can unmute and you can ask question.
Yes, sir. My question is about the role of stimulants like methylphenidate or modafinil in treating apathy, like the usual dosage in which it can be given.
Yeah, you are always right. If in apathy, one of the mechanism is stimulants, especially you can give modafinil or R-modafinil because of the less interaction. But the dosing has to be very low because it can have a paradoxical aggravation of activities. I mean, insomnia, you can get it some people. So there are some studies on improved motivation and apathy, but nothing more. Basically, non-pharmacological techniques, how to get involved and motivate them with other multi-stimulation therapy, etc., have to be done. And in the literature, there are mentioned, but don't be that much adventurous. Okay? Thank you.
Thank you.
Thank
you.
Yeah, Dr. Shrestha, you can ask the question.
Dr. Shrestha?
Hello?
Yes.
Yes.
Can you hear me?
We can.
Yeah.
Yes. My question regarding the use of antipsychotic drugs. I have been using antipsychotic drugs, especially the second generation, for dementia patients, for aggressive behavior and for psychotic symptoms. And so far, I have not seen any case of myocardial infarction or cerebrovascular accident. But in the literature, you come across that if you use antipsychotic drug for more than 3 months, then the chances of getting stroke and myocardial infection is much more. But I have not seen in my practice. That is one question. And second question regarding the sleep problem, because many patients, they come with sleeplessness. What is your, comment on the use of melatonin instead of using benzodiazepines or antipsychotic drugs for the sleep induction.
Yeah.
And number 3, you said that tricycle antidepressants also could be used for the depression or for agitations. But instead of tricycle antidepressants, for example, amitriptyline, which has more anticholinergic effects, I usually use in my practice the tetracyclic, the trazodone. That is much more effective. That is my personal experience. So these are the two questions and one comment.
Thank you. I will start from the last one. Tricyclic antidepressants have to be avoided because not only because of anticholinergic, but hypotension and cardiovascular toxicity. So that is out. If you use the term tetracyclics or heterocyclics, I will not discuss the varied classification. Which drug that you used to use it? Which drug that you are using it?
Trazodone.
Trazodone, in Europe, earlier it had come as an antidepressant, but the dosing was 600 milligram up to 400. But now in Europe, people give for just sleep only. Trazodone also, as Chitramohan has told us, can be given as a PRN medication in a smallest dosage, 25 milligram, if at all you need. But best is, in our day-to-day practice, mirtazapine is the best, which is being tried there. I usually use mirtazapine. Now, melatonin, many people will give melatonin because it is over-the-counter type of drug. So 3 milligram you may try. Secondly, the first part of your question, this is the second and third question I have answered. And these drugs, antipsychotics, cardiovascular side effects, forget it. Cerebrovascular side effects, it is highlighted. But we don't usually see in our practice. But you have to use it in a smallest possible dosage. And you are the best judge to titrate the dosage. But the literature says with the black box, etc., risperidone, and they say that. And the research also says that the mortality is high with these drugs. So you have to also believe them, believe the reports also. They are not fools. So we have to take care. That's all what I am telling. You have to take care when you select an antipsychotic. That also you select only if the target symptom really demands for a drug intervention. Non-pharmacological, you can try it. As a quickie, if you want to try, you can try anything. But preferably, you go for a second generation antipsychotics, lowest possible dose, which cannot produce hypotension. And there is a possibility of cerebrovascular events recorded, but maybe you may be lucky, but if you have to always educate them. If you require, even caregiver, relatives, you say, as it is like that, I am trying, most probably the patient can improve. Let me have a trial, but can have some side effects. Am I to use it or not? And record it in your diary, in your case file. Okay, thank you very much.
Thank you very much.
Dr.
Chintan, before you move on, these are pertinent questions. Let me make a few comments. Dr. Shrestha, trazodone, as Professor Mohandas said, may help in low doses with sleep, but you've got better alternatives like mirtazapine or melatonin itself. Is licensed in the UK for anybody over the age of 55 without the residual cognitive problems, etc. Trazodone for BPSD, particularly for anger agitation syndromes, there's absolutely no evidence. There's not a single randomized control study with trazodone for treatment of anger agitation syndromes in dementia. And the negative study, the failed trial, was Terry et al. In 2000. I mentioned it to you. In terms of, it's a real risk. And the risk was discovered. It's important for all 147 of you to know. The risk was discovered at the back of submission by Janssen Selag when they submitted 6 trials pivotal studies with risperidone in treatment of anger agitation syndromes for up to 12 weeks. That's when the risk analysis, like Professor Mohandas highlighted, is not imagined. It's a real risk. And FDA, when they did the analysis, they found the risk. So risperidone was never licensed by FDA, as you saw in one of Professor Mohandas' slides. But subsequent analysis, they found it is still a useful drug, and it did receive a license in the UK. Dr. Rajgopal and Dr. Ramakrishnan will know, for up to 6 weeks. It does have a license here. And the best evidence is still with risperidone. So it is a real problem, increase in mortality rates. It is not imagined. In my language, in Tamil, they say doctors have good kai rasi, by which they mean what Dr. Mohandas said. You are a lucky man, Dr. Shrestha. You've got the planets are with you. So you haven't seen any of these disasters. But the numbers needed to harm, we are men and women of science. The numbers needed to harm for one cerebrovascular event with risperidone is 100 in randomized control studies. So every 100 people you will see
1.5 fold. 1.5
no, that is the increase. Yeah, that's the increase. But in observational studies, it's like 27 to 34. Yeah, so it is a real issue in some, but fortunately, you haven't seen it. Chintan, next one.
Yeah, Dr. Khalid Azam, here's a question.
Ramakrishnan had, from UK, Ramakrishnan had some question.
Okay, Ramakrishnan, unmute yourself.
What is the question?
Mohandas and Chitramohan, it is very nice to listen to you. As usual, it is a routine, ritual now. Every, Saturday afternoon, whatever other problems are there, we sit in front of the telly and, the computer and watch this one. That's a part. Sorry, Mohandas, I would like your comment on, because I've seen people using melatonin. Obviously, I do use melatonin, but I have seen people using melatonin and short-acting benzos like lorazepam or clonazepam also for sleep. I have not fully understood the rationale behind it. Could you please shed some light on it? Thank you.
Melatonin only is a sleep-inducing drug. Basically, in a demented patient, you have to change the environment depending upon sleep-promoting, sleep hygiene, sleep-promoting environment, and melatonin. If you cannot do it, better to give it mirtazapine 7.5, or very rarely I have given trazolone 25 milligram. But it is a practice. You are absolutely correct. Benzodiazepine receptors. People are targeting that. Clonazepam, nitrazepam, people give. But old people, it is a very big risk. Disinhibited behavior, confusional state, further cognitive decline, all these things that you know it. But here in India, somebody has asked whether you have to get the consent. Where is the consent? The pharma people, even if you prescribe for 1 month, sometimes the patient can come to you after 4 years. How do they get the medicine? They know the pharmacist and everything. Or if the drug is withdrawn from the market, they will come. This drug is not available. Why don't you do it? So, we do not respect our clients. The clients do not respect you also, because they want the ease. They have to pay for your consultation. They go to the medical shop, and medical shop people are also so-called pseudo doctors, and they will comment on the drugs and they will dispense it. So we know that though we talk about rational thing, we live in an irrational world. Okay, thank you.
Thank you, Anand.
And Ramakrishnan, just to add to that, be careful with the benzos for the reasons Professor Mohandas has already highlighted. But sometimes in vascular dementias in particular, if you want to avoid antipsychotics, where the risk is higher than in Alzheimer's disease, the cerebrovascular risks, sometimes you have to resort to short-acting benzos, but use the shortest-acting benzodiazepine for a shortest possible time. Sometimes if you start somebody on citalopram, for example, it takes time to cut out the behavioral agitation, etc. So whilst you are waiting for the citalopram to work in lower doses because of QTC concerns, you can use in a controlled manner some of these short-acting benzodiazepines and tell the nursing staff or the residential home staff or carers themselves if they become ataxic or they're highly sedated or more confused not to give the medication. If you are using it, use it for a short period of time. That would be my practical advice.
In my slide, basically, it's a stepped approach that PRN medication, lorazepam, can be given or trazodone. I have already noted.
Sure.
But the lowest possible dose, even clonazepam, you can give it, but you should not give for long time, only as and when, only for a short while, otherwise it can produce problem. Okay.
Yeah, sometimes we use only in situations where lorazepam, because it is an injectable form. Because many times patients do not accept the medication, and in that case, as you said, on a PRN basis, we have given lorazepam.
That's more for rapid tranquilization, isn't it?
Yes, that's true.
No. Rapid tranquilization, the concept has come from not intramuscular but intravenous. Lorazepam can be given intramuscularly. Diazepam should not be given intramuscularly.
No.
Okay, lorazepam, but intravenously, if you give, you have to think of the respiratory problem. So intramuscularly, you can give it. Okay.
Here, Mohandas, in the UK, the used rapid tranquilization is used for IM lorazepam. That's the difference.
Unfortunate. I think they have to know the history of rapid tranquilization.
But this is how they use it here.
I am familiar with the complete history of rapid tranquilization.
Sure. But it's worth pointing out at this stage, for the benefit of all the audience, there was a systematic review by Tampi et al. In 2014, which concluded the available data
Rajesh Tampi from Trivandrum.
Sure. So available data, although limited, do not support the routine use of benzodiazepines for the treatment of BPSD. It's the conclusion of that paper.
Rajesh Tambi's articles are there in 2020. Two beautiful reviews had come. I think I have mentioned somewhere. I do have the complete articles. Okay.
Yeah.
All PDF material is there.
Thank you.
Yeah. Next question, Dr. Khalid. If you can unmute and ask question.
Dr. Khalid. He might have left. Go to the next question.
Yeah, Dr. Himangi, you can ask the question.
Hello, good evening, everybody. I know mirtazapine is the best antidepressant, but many of these patients have diabetes, and then we are worried about diabetes. So, which is the other antidepressant better? Because most of them have hypertension, diabetes, everything. And
you are correct.
Otherwise, neurologists prefer quetiapine over risperidone and other drugs. And you are saying that risperidone is better. So, that I want to ask.
Yeah, you are correct. If there is a comorbidity, if you are targeting depression, you have to give antidepressant dosage. The best antidepressants are without drug-drug interaction is SSRIs, especially escitalopram and sertraline. But unfortunately, in elderly, that can produce SIADH, hyponatremia. So what is the treatment for hyponatremia? Mirtazapine and other agents, hyponatremia, which I will not go into. Now, if a person is diabetic, avoid antidepressants which will produce weight gain. And mirtazapine average dose for antidepressant is 30 to 45 milligram, but it is a modest antidepressant. Now, that will produce weight gain. So that is why it is not good for diabetes. But here you are giving only 7.5 or even half of it. There is no problem. Now your neurologist talk about quetiapine, fine, we respect the neurologist. And some people give clozapine, lower dosage, yes, but If somebody is using, wonderful, that evidence is not there except for Parkinson dementia. Okay, and some other condition. Quetiapine, we don't have enough evidence. So you can discuss with your cardiologist or neurologist, discuss with them, show the evidence, and see whether we can improve the prescription pattern if possible. Okay, thank you.
And Mohandas, you talked something about gabapentin. If the patient has neuropathy and she is on high doses of gabapentin, then what precautions we have to take for other medicines?
Neuropathic pain, the best two drugs are, one is gabapentinoids and antidepressants, especially tricyclics. Okay, you are correct. But here, if there is a polyneuropathy, you cannot can use gabapentin. It is not going to correct your BPSD or neuropsychiatric symptoms of dementia. And you can control with some other drugs are there. Otherwise, you can titrate the dosage. Okay.
Okay, thank you.
Dr. Hemanji, Dr. Mohandas has answered most of your questions. Just to clarify, I only said risperidone is a good drug and a licensed drug. That is only in Alzheimer's disease. And I will definitely avoid risperidone in Parkinson's disease psychosis, and we've already discussed your treatment options in Parkinson's disease psychosis. And the other point to make on top of what Professor Mohandas has said, any of the newer anti-epileptic medications, there's absolutely no evidence in behavioral and psychological symptoms in dementias, particularly anger agitation syndromes. Quetiapine, as Professor Mohandas has already showed you, has some low-quality evidence, maybe 2 studies, but there's one negative study with carbamazepine, there's one negative study with oxcarbamazepine. Of course, it has multiple interactions and other neurological side effects, so we hardly use it, but valproate is a drug I will like to put the boot in again, to be avoided at all costs because it led to cognitive decline. Professor Mohandas has already told you correctly, sertraline and escitalopram are good options, but there's a small risk of hyponatremia, then mirtazapine comes up in the chain. I generally don't have any problems with mirtazapine in older patients, but certainly in younger, older patients under the age of 75, I generally avoid mirtazapine because of its metabolic side effects. But in older patients, it's not so much of a problem, particularly the emaciated ones in nursing homes. It's not a problem, but it is a drug of choice in hyponatremia anyway. But there was a very interesting study with citalopram, follow-up study from CIT-AD, showing the impact on mortality. What is the long-term impact of antidepressants on mortality in dementias? Before we get to that, there are 2 areas we need to be concerned about. One, some of the drugs, like Professor Mohandas said, are strong anticholinergic drugs, like paroxetine, in response to P.I.E.C.E.S questions. And so a cholinergic burden can worsen the cognitions. So long-term use of antidepressants for in BPSD can theoretically worsen the cognitive decline. And the second thing that can happen is there are studies to show it increases falls in dementias. So be aware of these
frailty, in frailty, frail patients. Yeah.
Sure. So be aware of these things is what I'm pointing out. And the last good news with long-term use, and there was a study by Inachi et al. In 2016 that showed antidepressant treatment for 3 consecutive years before diagnosis of dementia is associated with lower mortality risk of all dementias and Alzheimer's disease.
Thank you so much.
And I echo the comment on valproate, especially hyperammonemic encephalopathy is more in elderly. There are neuroplastic effect of valproate, but in dementia with BPSD, there are 6 reports initial, but currently valproate or divalproate should be avoided in dementia. The others are all case reports. And now the consensus is, as Chitramon has told, please avoid it. Not only, even lower dosage, it can produce hyperammonemic encephalopathy, even bleeding disorders, etc. in elderly. Okay, thank you.
Next question, please. Anybody unmute and ask Chintan's
Dr. Ruchi Sharma has a question.
Oh, lovely.
Hello.
Yes.
Hi, Dr. Mohandas. Thank you for the brilliant session as always. I have a question on the ratings scale. That is what. How efficient is a rating scale like Cambridge Behavioral Inventory in terms of distinguishing between FTD and AD, or any such scale for that matter?
Initially, the Addenbrooke scale, the 100-point scale, came as to differentiate FTD and Alzheimer's. Initially, it did come. It has gone for modification, revised on the mini version. Cambridge also, they suggest that it can differentiate.
Yeah.
How good is it? I don't know. I haven't used that scale. Addenbrooke's in the Malayalam version I was using because Madhuranath was there in Srijitra at that time. I had Raghunath with me in 10 years back in a light. At that time, nowadays I am not using much. But if you are doubting, if you just do it, then you have got DAPHNE scale, especially for frontotemporal dementias. DAPHNE scale, you can easily use it. And there are frontal battery scales, plenty of scales. I have mentioned only some of them. Okay, thank you.
And Ruchi Sharma, you heard Madhuranath's presentation last week. I saw you in the audience, and he did show a number of scales for frontotemporal symptoms. Yeah. But his original publication when he was in Cambridge in the early 80s was about differentiating between AD and frontotemporal dementias. The whole concept of his first, he was the first author in the first ACE publication, and that is about differentiating.
That was 100-point Addenbrooke's, the first. Yeah. Now we have got the recent one, mini Addenbrooke's also.
Mini ACE.
This is not the time to discuss scales. That's why I didn't want to. Okay.
Sure, sir.
Chintan, next one.
Dr. Ivan has a question.
Dr. Neto.
Yeah, I wanted to ask Dr. Mohandas, in India, is it mandatory to take a formal consent before giving antipsychotics to elderly patients with NPSD?
No.
Have you taken, sir? Have you taken in writing anything of any patient?
No. I usually discuss with the relatives. Here, all the people come with the relatives. They have got so much faith in you, confidence in you. We will explain them the good and bad things about it. Unlike UK and Western countries, even for antidepressants, you have to get the consent. But we usually inform it is a verbal consent. There are differences in the so-called informed consent in India and other parts. So I had even talks on how informed is the informed consent. I had talked 2-3 places. How informed is informed consent? And so here we don't, because here we are interested in the betterment of the clients, and we have got good rapport rather than wasting time to record and not it. Only the clinical job to protect yourself from the bureaucracy or the so-called litigious circle around you. We don't have any problem.
If I could add to that, Dr. Neto, in UK also we don't. But what we do, I'll tell you what we do. Well, Professor Mohandas has already said many of the points. I'll just underscore some of the points and make 1 or 2 new points. Firstly, all of us here, 117 are still here, must have the scientific rigor to first identify and note what is the target symptom we are treating. That's very important. You can't just blanketly give a drug and say, I'm treating everything. So you have to say, I'm treating psychotic symptoms, auditory hallucinations, visual hallucinations, behavioral agitation, physical aggression, verbal aggression, or both. So you got to define the target symptom. It's in your documentation. And then you have to demonstrate you have failed. Non-pharmacological treatments have failed. All major clinical guidelines will dictate that non-pharmacological treatments must be tried first. So you go step by step. You've tried that. That has failed. Now you point out this is causing significant distress to the patient and to the caregiver. Having an evidence-based drug from the beautiful list of main pathway or the traffic lights Professor Mohandas showed. You choose your drug for the reasons you want to use it. and then use the lowest possible dose, go slow, and make every attempt to withdraw it. And if you're using adjunctive medication, same principle. Always, like Professor Mohandas said, keep the family on your side. Here, the patient is likely to be incapacitated, particularly in moderate to later stages of dementia. So you can't get an informed consent. But the concept of informed consent has finally come into our UK practice. Supreme Court ruled in a case, I won't bore you with detail, the so-called Bolam defense. Bolam defense was about acceptable practice within a responsible body of medical opinion. So in Trivandrum or in Kerala, state of Kerala, or state of Karnataka, whatever, UP, it is acceptable practice we cannot hide behind acceptable practice within a body of medical opinion anymore. It is what an average man will want to know about a side effect. So if mortality is an issue which we are not imagining, like Professor Mohandas highlighted in response to Dr. Shrestha's question, we know this is a real problem. So we need to tell them, the relatives, this is the risk-benefit analysis. This is why I'm recommending it to you without wasting time.
Now,
next question.
But before you continue, in Indian Penal Code, there is a clause in the good interest of the patient.
Best interest, yeah.
And that I usually write whatever we talk also in the good interest of the patient. And I have gone to the court also to argue it, and they agreed. Yes, we do that. Because even recently, Supreme Court has come with a law that doctors, even they are protected from consumer court violation and also criminal. Many people used to be arrested earlier. Recently, it has been completely lifted. Recently. So otherwise, they will be having criminal negligence. No doctor is negligent that way. They do for the betterment of the client. That was the argument recently. It has come out in the Gazetted. It has come out. And I think I do have the copy. Somebody has said to me, because my relatives are judges. That is the reason.
I think you have convinced me. I'm going to move to India to practice.
Yes, welcome.
Yes, I'm coming to Kerala. I like the Kerala food. I'm going to come to Trichur.
But politics is the biggest problem. It is almost like Corona here. It is worse than Corona here.
No, on a serious note, in response to what you have said, that's very sensible. In the UK, Dr. Rajagopal and Anand Ramakrishnan will know it's going the other way. It's moving away from medical paternalism to what they call as Article 8 rights, right to private and family life under Human Rights Act of 1998. They're going completely away from medical paternalism to what the patient's point of view, viewing everything from the patient's point of view, and the pure best interests arguments will not wash. You still have to go through the informed consent.
Chitra, I will not comment anything here. I have argued here right and left in India and abroad. Even the human rights principle, India is also signatory.
Yeah.
But do you know the history? How was it passed? It was not passed unanimously like that. There is a very big problem. And we talk about evidence base. Where is the base? Many of the things are evidence biased and eminence based. And we are interested in evidence informed. Okay.
Sure.
Right. Thank you.
Next question, Chintan.
Sir, I think we have surpassed the time. If anybody would like to ask
one last question.
Yeah, I think last question we can take. Yeah, if anybody has a question, please ask.
Sorry, can I just mention something?
Sure.
It's not a question, but just on taking on from one of the slides Professor Mohandas had kept about snooze therapy. I mean, for trainees and people who don't know, but I mean, that's a multi-sensory stimulation that, I mean, we usually use it in the Western area where there are lights and smell. And I think Dr. Ramakrishnan did mention in the chat. So that's something which we use here. It's not fully evidence-based. There are not many research on that, as Dr. Mohandas mentioned. But some areas we do use that. It's to make optimal stimulation so that the aggression is reduced. And the cons of it is that sometimes people, when they are agitated, we can't use it. It's only when they are much more settled that they use it, and then their threshold comes low. So that's, I thought I'll just add that.
Thank you very much. Thank you very much.
Yeah. So, sir, next week announcement if we can do, and then we can.
Hello, can I?
Next,
hello?
whether Madhu is there.
Dr. Madhusudan, he was there, sir, initially, but I think he left now.
I think next week or further week, we have been finalized it. Next week, we will wind up with the show with the Alzheimer's, not dementia as such. Now we might think of the headaches. And I will entrust money to do that. We will start with the historical evolution, then we will talk on migraine, the clinical approach, then neurobiology of migraine or cluster headache, etc., treatment targets, etc. That Madhu will outline it. But incidentally, when I talk to him, historical evolution, I am supposed to talk about it. If he wants me next week, I am ready to speak on historical evolution of headache. If he wants me to do tomorrow, I am ready. Or further week, that let him decide. Okay, tomorrow anyway, I have got a program with Chitramohan.
Hello, can I say something? Hello?
Yes, please, sir.
Regarding the informed consent. Hello, can you listen to me?
Yes, we can hear you.
Yeah. Regarding the informed consent, I'm just telling one real story from Nepal. About 20 years back, one of the neurologists, he gave carbamazepine for generalized tonic-clonic seizure. The patient was a young girl of 16 or 17, and she came with the mother. And nothing happened for about few days, but after few days, the patient developed Stephenson-Johnson syndrome. And it was very severe. And the patient ultimately went to the court, and the neurologist had to pay the compensation. It was 20 years back, imagine. Now the Consumer Court Act has come to Nepal, and we have to be very careful. Of course, I mean, as Dr. Mohandas said, it is not possible to take informed consent from each and every patient, because each and every patient, they come with the relatives. So we are interested. So they have confidence on the doctor. But sometimes really it happens. So what I mean, personally I have done, in my prescription pad, in one side, I have written all the possible side effects and what are the precautions to be taken. So just to, I mean, protect myself if something happens. Because you cannot say each and every, I mean, side effects to the patient. I mean, it takes time. And sometimes, you know, the patient, they don't understand also. And if they know all the side effects, I mean, they are very hesitant to take the medicine also. So it is a problem. So it is a real problem.
No, you have to psychoeducate. You have to psychoeducate. You have to document in your case file. But in the prescription pad in UK, you are not, in order to write it, you have to get their consent. Anyway, there are so many technical problems. These things I have faced. Not only this.
Not in the prescription, but in one side. You know, it is written.
I have attended court on n number of cases to argue for an expert opinion. I got answers to all these things. Today we do not have time because already, otherwise I would have answered you in one of the leisure time. I will talk on how informed is informed consent. Even if you see the IPC category, there are 3 areas which are very conflicting to put the IPC. Anyway, we will discuss later. Okay.
Thank you, sir. Dr. Thank you, Chitramohan, sir. I think there was a lucid discussion and very wonderful.